Archie Clements is a professor. He's also a vice chancellor at the Faculty of Health Sciences at the University of Curtin in Australia. That's in Perth, Australia. He's worked previously at Imperial College London and the University of Glasgow, and he has a PhD from the University of London. His research background is in the epidemiology, control, and elimination of infectious diseases. First of all, can you just talk to me about Australia, Archie? I mean, it's actually fared pretty well compared to other countries.
Yes, we've been very fortunate in Australia. We've had a fairly small epidemic here, and we're well past the peak. At the moment, we're only getting fairly small numbers of cases, between 4 and 15, that sort of range. I think we can put that down to a combination of good luck and good management. Obviously, being quite an isolated country, we don't get that high volume of international travel across our borders. And we have a very low population density even in our cities, and I think that's helped us contain the epidemic. But on top of that, we've also had, I think, a very good government. I think the government response has been very good. Like the United States, we have a federated system, with each state being responsible for its own healthcare system. And what we've seen in Australia is that the state governments and the Commonwealth government have collaborated very effectively in developing clear messaging and gaining the trust of the people and implementing, I think, fairly effective public health initiatives.
I mean, Australia is really opening the doors right now, probably ahead of many societies. Do you think, not only in Australia, but around the world, that there's a danger of opening up too quickly? And again, that leads us into, is there going to be a second wave? And like 1918, that second wave was much more deadly.
I think it's a little bit of a different situation to 1918. In 1918, the public health response was really nowhere near as sophisticated or well developed as what we have now. And the waves of influenza in 1918 really related to the levels of underlying population immunity and really the unfettered movement of the virus across populations. Whereas here, I think what we've got is a much better understanding of the dynamics of viruses. I think we have effective public health responses that we put in place, social distancing, mobilisation of resources into the health sector as needed. We also have a much healthier population. So in 1918, they'd just come out of 4 years of war. The population was undernourished. There was extensive comorbidities with other conditions. We don't really have that now. And of course, the 1918 pandemic, that influenza virus was much more dangerous for young people than the current virus. So I think we're in a very, very different situation. I don't anticipate we'll have a big second wave like we had in 1918, but what we may see is numbers of cases waxing and waning according to the level of public health controls that are being put in place in countries around the world.
Well, just very briefly, let me push you on the second wave. Is it going to be bigger than the first wave?
Well, what I think we'll see is, and we are seeing it at the moment, every country around the world is at a different stage of the epidemic. Every country's on a different part of the epidemic curve, and we can see, for example, at the moment, countries like Brazil and Russia are still in the exponential phase of growth, whereas countries like Australia and some countries in Southeast Asia, for example, have moved past the peak, and we're now at that tail end of the pandemic where we're seeing sporadic cases. So I don't think we'll see a coordinated global second wave. What I think we'll see is that wave progressing across the globe at different times.
Will you see a second wave that's larger in the United States, where they're approaching 100,000 deaths? Will you see a second wave in the United Kingdom that, we're well up over 36,000 deaths?
Well, of course, it's very, very difficult to predict with certainty, but I think what we're likely to see is in the United States, if there is a relaxing or premature relaxing of social distancing and other public health responses, we'll just see a prolongation of the pandemic. So we'll see it stretching out over months, even potentially into next year. And the same may happen in the United Kingdom. I don't think that we'll get explosive waves and then significant drop-offs. I think what we'll just see is a much prolonged peak in the pandemic in the United States.
You were at Imperial College, and Imperial College really led they were kind of the tip of the spear on modeling, if I can use that term, predicting dire numbers, which didn't come about on the scale that they predicted. Do you think that modeling was at fault, and that many governments were at fault themselves for following that modeling? And many governments, including the Trump administration, feel that they were cheated by some of those forecasts, and that they shouldn't have taken as harsh a lockdown as they did.
Well, I think the starting point is that no models are perfect. And I think that the best modelers in the world, and I know the people at Imperial College, will be communicating the uncertainties and caveats associated with their models. It's really up to the governments, the politicians, to interpret those models appropriately and seek advice from the experts. I think that what the models were showing was, if no public health response was put in place, this is the scale of pandemic that we would expect. If we were to rely on the build-up of herd immunity, this is the level of mortality that we would expect to get there. Now, of course, no country has refrained from implementing public health measures. No country has allowed the virus to spread freely across the population, and therefore we haven't seen the scale of illness and mortality that those early model estimates presented. I think, if politicians were saying that they felt cheated, it's because they either don't understand or they don't wish to understand what the models are telling them. It may well be that what the models are telling them is not convenient for political purposes.
The United States was late to lock down. Would you say that? And do you think the UK was late to lock down, and that's why we're seeing such very, high and tragic numbers of deaths in both the countries?
Yes, I think they were too late to go into lockdown. The Director General of the World Health Organization was urging countries from the very early stages of the pandemic, whilst the pandemic was still largely contained in China and other areas of Southeast Asia. Before the pandemic really hit Europe, the Director General of the World Health Organization was telling people, you must act now, you must prepare, you must put in place public health measures to prevent the pandemic. Many countries didn't, or they did it too late, and that includes, unfortunately, the United States and the United Kingdom. And now we have the President of the United States criticizing the World Health Organization, when really, if he'd followed the advice of the Director General, we would not have seen the scale of death and illness in the United States that we're seeing now.
You mentioned China, and Australia obviously relies on a huge amount of trade with China, and China's threatened Australia for supporting that investigation into the origins and the Chinese response in the initial outbreak. Can you just explain to me, in terms of the science of this, never mind the politics of it, why is it important that we get to the bottom of that, and what do you think we still have yet to learn?
Well, I think that we can be fairly confident that the virus originated from a spillover from a natural host into the human population, most likely through the trade in live wild animals. We can be confident of that because it's been known for a long time that there's a large diversity of coronaviruses that are present in wild animal populations, particularly in bats, and that as humans come into contact more with those wild animals, either through population growth, incursions into natural environments, increasing fragmentation of natural habitats, wild animal trade, what you see is more interaction between humans and wild animals, and then you increase the probability of spillover events from happening. So that scenario is well understood. There's a lot of evidence to support that as the origin of many emerging pathogens. There's nothing to suggest that that's not the case in this particular situation. And really, I think what we're seeing is a certain amount of obfuscation. And you rightly say that this is my expertise lie very much more in the science than in the politics, and I can't claim to understand necessarily the motivation for political obfuscation, but really, in my view, that's pretty clearly what's happening here.
Do you think the outbreak began in a lab in Wuhan?
think it's very unlikely.
Why do you say that?
For the reasons that I've already explained, that the process that led to the spillover of this virus into the human population is well understood, and it's happened on many occasions. And there's no virological evidence, there's no genomic evidence in terms of the makeup of the virus that suggests that it is in any way modified or altered by human scientists.
It may not be altered, or it may not be weaponized in that kind of sense, but it may be that they were studying bad viruses in the lab in Wuhan, and it may just be simply that it escaped from there, also as a possibility.
Well, I think it's a remote possibility. I think, you know, given the level of risk, when you're talking about a very highly regulated laboratory environment with very high standards of biosecurity, you compare the risk of an accident happening in that scenario with the risks associated with the uncontained and unregulated trade of wild animals, then, you know, the magnitude of the risk of the latter is very clearly much greater than the magnitude of risk of the former.
I'm very curious what, in the last remaining minutes that we have to talk about, what you think we've learned about this virus as we've come to try and deal with it since January, February, March. In an interview I watched that you did recently, you talked about immune responses and a possible breakdown in immune response. Did I get that wrong?
I'm not sure which interview you're referring to, but I think what we've observed with
you were really talking about immunity and whether immunity is what we know about immunity, and whether we can rely on immunity once you've had the virus and you've had an immune response to it.
Yeah, so coronaviruses are dealt with by a different part of the immune system so for example, influenza viruses, and it can be quite challenging, for example, to develop a vaccine that triggers the right part of the immune response to effectively prevent or contain infection by a coronavirus. They tend to invade through the upper respiratory system, which has got a different immune system to the lower respiratory system, the lungs, for example. And what we've seen is in natural infections, there's a variable immune response. So some people have a strong immune response, particularly those people who have a severe infection, but people who've had a more moderate infection tend to exhibit a lower grade immune response. It's not currently understood the duration of immunity. So what you typically see with immunity is that the level of immune response increases quickly after the infection, then plateaus and then drifts off, leaving you susceptible to reinfection. For coronaviruses, that period appears to be shorter than other viruses where we have effective vaccines. So there are a host of challenges associated with developing a vaccine. I think that, you know, given that we're now seeing over 100 groups around the world working on a coronavirus vaccine, I think it's very likely that we will find one. And then the question will be how quickly and I guess equitably a vaccine can be produced and then rolled out across the world. And, you know, will the coronavirus still be with us? Will we still be in a pandemic situation when that vaccine is ready to be released? And that, I think, you know, that's an unanswered question for now, but that may have some bearing as on whether or not ultimately a vaccine is actually produced and rolled out.
Archie, do you think that the virus is mutating? Is this a fixed target for people working on vaccines, or is it a moving target?
From my reading, it appears that the virus is relatively stable, and the vaccine manufacturers and scientists who are looking at this are fairly confident that they can create a vaccine that will be effective in years to come. It doesn't appear to be mutating as quickly as, for example, influenza viruses, where there's a need to develop new vaccines every year because of changes in the virus, and also the diversity of influenza viruses and the need to target vaccines of particular strains of influenza on an annual basis. At the moment, it doesn't look like that situation is arising for coronavirus.
Why do some people have such a strong immune response and then others do not? So why do some people get just hit over the head with this to the point that it may result in a fatality, or they have to be hospitalized, and other people have very mild reactions? I know it's a question we keep asking, but do we understand the answer any better?
It's the $60 million question, and we don't really know the answer. It could be a combination of genetics, previous history of exposure to coronaviruses. We know that some of the people who die from COVID-19 have an overactive immune response, a so-called cytokine storm, and that probably relates to how primed their immune system is to respond to infection with coronaviruses. That may relate to their past exposure, their past history of exposure to coronaviruses, potentially to other viruses. Really, we don't know. I mean, it may also relate to the dose of virus that people are infected with when they initially become infected, and that has been one of the explanations people have put forward for why so many healthcare workers, for example, have had severe infection, because being in close proximity with severely ill people, the thought is that they may get a higher dose of virus. So those are a couple of reasons that may account for it. It might relate to genetics, might relate to immunological history, and it may relate to dose of exposure.
I'm puzzled by this idea of a higher dose. I mean, I thought if you come into contact with a virus, you're in contact with a virus. It doesn't matter whether there's a cup full of it or a bucket full of it. But apparently it does, and it depends on the person you've come into contact with.
Yeah, it's a challenging concept, but yes, and it's seen with most other viruses. So even, for example, HIV, that you need a certain minimum dose of the virus before an infection sets in effectively. And it's not really, I guess, known what that dose is and why it might vary between individuals, but it doesn't just require one virion to infect an individual to lead to replication of the virus in that person and for an infection to take place. It usually requires a minimum dose of viral particles.
Would you take a tube? Would you take a bus? Would you get on an airplane right now?
Well, in Australia, I would definitely get on a bus or on a train. I wouldn't be getting on an airplane to travel overseas right now. Airplanes are actually, more greater at risk of being infected by another person in an airplane than you are being in any other enclosed space, whether it's in an office with somebody, in a restaurant with somebody, in any other enclosed space with them. So the fact of being close to someone in an airplane is no more risky than being in any other enclosed space. I guess what is risky about being in an airplane is that it brings people together from many, many different locations for an extended period of time. If we're talking an international flight to Australia, you might be in a small enclosed space with people for 12 hours. So that's really where the risk comes from with being in an airplane.
So you said you would get on a tube or a bus there, but you wouldn't. I assume you wouldn't do it in London right now.
No, I wouldn't. And that's the reason for that is in Australia we don't have evidence of extensive community transmission. Obviously, in the United Kingdom, you still have evidence of significant community transmission, and that's why I think it's a little early for countries like the United Kingdom and the United States to be actually looking at moving out of lockdown, moving out of social distancing measures, because you do still have existing community transmission, and once you take the shackles off, the virus will rebound, and I think that is a challenge.
Sending kids back to school, is that wise, or is it because they think it's safe, or do you think that promotes herd immunity and that's kind of the thing they don't talk about, and that's why they're sending them back?
No, I don't think that's the reason why they're being sent back. I think the reason why children are being sent back is because they're at very low risk of severe consequences of infection. They also don't seem to be contributing significantly to transmission of the virus to other people. So in a situation like the one that we have in Australia, where we have very little community transmission, I see that there's absolutely no reason why children wouldn't be going back to school. The other reason why it's important, or the reason why it's important for children to go back to school, is because of the impact that it has on people's jobs, livelihoods, and the economic impact. And I think in any epidemic response, you need to balance the economic consequences of a decision with the health consequences. And I think that sending children back to school is a relatively low risk one from a health perspective and a very high gain one from an economic perspective. So in a situation like we've got in Australia, I would be in favour of it. I think it becomes a little grayer when you're talking about countries where you've got still lots of community transmission. Whilst I think that children contribute very little, overall, you probably need to be doing everything you can to dampen down transmission in countries where you're still seeing quite a lot of community spread.
Herd immunity necessary? Is it inevitable, or do you think that maybe it's not right now because the virus may die away over the summer or for at least a few months?
So I think herd immunity is a positive byproduct, I think, of the infection spreading in the community, but I would never use it as a strategy for containment of the epidemic, largely because the costs in illness and death of achieving a level of herd immunity that you would need in order to control the epidemic is so high that it's not worth it. By far and away, the best way of achieving herd immunity is through having a vaccine. So doing it in a controlled way, not in an uncontrolled way, through allowing the virus to spread in an uncontained way across the community.
Last question to you, and I thank you for your time. Do you think, do you agree with some of these predictions that say viruses like COVID-19 are going to come more frequently and we're going to have them more often?
Yes, I do. For some of the reasons I mentioned earlier. So human population is going to continue to grow throughout the 21st century, particularly in tropical areas of the world, and also in parts of the world where regulation and the ability to ensure sustainable population growth, where the ability to do that is most limited. That's going to bring human beings into contact with more and more naturally occurring pathogens. Unplanned urbanization, unplanned deforestation, unplanned growth of agricultural industries in areas where there's a greater likelihood of coming into contact with natural pathogens is going to result in more frequent spillover events. And I don't think that we'll be waiting another 100 years for a pandemic of the scale of the Spanish flu and of the scale of COVID-19. I think these things are going to be happening with increasing frequency. And really the salutary lesson from this pandemic, which whilst it's been a horrendous pandemic and has resulted in widespread mortality and illness, it could have been a lot worse. So we need to learn from this one. When the Director General of the WHO says, countries, get your act together, sort out your borders, sort out your health systems, put in place public health measures, hopefully with the next pandemic, those countries will act more quickly. And hopefully
Archie,
we'll
Clements.
invest more in science.
Sorry, go ahead.
Hopefully we'll invest more in science. Hopefully we'll invest more in public health. And in Australia, we have invested for a long time in preparing our public health workforce. Again, this is a lesson that we need to learn for the future.
Archie Clements, Professor, Vice Chancellor at the Faculty of Health Sciences at Curtin University in Perth, Australia. It's such a pleasure to talk to you, and thank you so much.
It's a great pleasure, Dana. Thank you.